Welcome to The Code Tray, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
But next, we'll move on to our next journal club by Mallory Schwartz. She is a current PGY2 emergency medicine pharmacy resident at the University of Cincinnati Medical Center, and I will let her share her screen and take over.
So some background, stroke remains a major cause of death and disability worldwide. Despite current secondary prevention strategies, approximately 5% of patients experience a recurrent stroke within 1 year. Current antiplatelet therapies reduce risk but do not eliminate it, and prolonged dual antiplatelet therapy could potentially increase the risk of bleeding for our patients. And because residual thrombotic risk remains despite guideline-directed therapy, there is an interest in identifying safer antithrombotic approaches that can further reduce recurrent ischemic events without sustainable increased bleeding. And so this is what led us to potentially looking at these medications. So prior studies of these medications, so we have the Pacific Stroke Study, and so this study, what we're going to be looking at is called the Oceanic Stroke Study. But first, I really just wanted to talk about the established rationale behind the trial and why this trial was created. And so factor 11, or XI, has become an attractive anticoagulant target because it appears to contribute to some sort of the pathogenic thrombosis while playing a relative limited role in normal hemostasis. And so really the hope is to find a factor 11 or XI that can reduce thrombotic events while causing less bleeding than our traditional anticoagulants. So there's been several studies looking at this in hopes to find a new medication that we could bring to market that could potentially reduce our bleeding risk while also preventing clots. So several phase 2 trials evaluated this concept. We have the Pacific Stroke Study, and this looked at Asundexian and patients with recent non-cardioembolic ischemic strokes receiving standard antiplatelet therapy. Although this trial did not meet its primary efficacy endpoint, it was really looking at what potential dosing that they could be using plus antiplatelet therapy in comparison to placebo and antiplatelet therapy. And what this really signaled to from this trial was that potentially using that 50 milligrams daily was the kind of ideal blocking that we needed for the factor 11A inhibitor. And so that's what they kind of led to the specific AF trial. So this looked at atrial fibrillation specifically with Asundexian versus apixaban, and they used the higher dosing. So we had the 20 or the 50 milligram daily dosing. And this study found substantially lower rates of major or clinical relevant non-major bleeding with Asundexian. However, it was a phase 2 trial, so safety studies was not powered to determine whether Asundexian was effective as apixaban for preventing strokes or ischemic embolism. And so really we can't make any conclusions from this study, but there was lower bleeding than apixaban. And lastly, we have the exempathic trial. And so what this looked at another novel therapy, Milvexian, which is also kind of a part of this class that they're looking into of the factor 11A or XI medications. And so they looked at patients with at risk of ischemic stroke or TIA receiving dual antiplatelet therapy. And similar to the specific trial, the primary endpoint was not met. There was exploratory reduction in asymptomatic ischemic stroke without a significant increase of major bleeding. So overall, these studies really led us to potentially looking more into Asundexian and potentially other factor 11 inhibition could preserve a favorable bleeding profile while also providing promising, though exploratory signals for potentially reducing ischemic events. And so this is what kind of led us to this trial. So why this study? So they're looking at it plays an important role. So factor 11 plays an important role in the pathophysiology of the thrombosis. And as we can see in the coagulation cascade, I have it marked at the top in a box. So we have the factor 11 and factor 11A. It has some potential it amplifies thrombin generation, promotes pathologic thrombosis, and has a limited role in actual hemostasis, while we have Asundexian that is going to be blocking that factor 11A inhibitor. And what they did find that it about 90% of inhibition with 50 milligrams daily. And so that's what they really took into this study is we likely need 50 milligrams to actually cause an effect and want to use that to compare it to other agents. So really the investigators hypothesized that adding Asundexian to antiplatelet therapy would potentially reduce recurrent ischemic stroke without increasing major bleeding. So current recommendations, just wanted to go through these. So current AHA and ASA guidelines recommend dual antiplatelet therapy for 21 to 90 days after minor ischemic stroke or high-risk TIAs, followed by a single antiplatelet therapy for long-term prevention. However, recurrent ischemic events continue despite these recommendations. And so really just highlighting the need we need additional therapy or more options for our patients if they were to have recurrent strokes. And so this is what led us to the question of the oceanic stroke research question. So in patients with acute non-cardioembolic ischemic strokes or high-risk TIAs, does adding Asundexian 50 milligrams daily to antiplatelet therapy reduce recurrent ischemic stroke compared to placebo? And so for the study design, so this was a multi-center randomized double-blind placebo-control event-driven study, and it was a phase 3 trial. And so eligible patients had to have a recent non-cardioembolic ischemic stroke or high-risk TIA and were randomized within 72 hours of symptom onset. Patients either received Asundexian 50 milligrams daily or placebo in addition to the standard antiplatelet therapy. And I wanted to review what the standard of care, what they had labeled. So it really just depended on the center, on like what they chose and what the physician chose or pharmacist, et cetera, chose. But they had multiple different definitions within the supplemental data. So they had a single antiplatelet regimen, a dual antiplatelet regimen, and they also had secondary stroke prevention that they were also monitoring. So investigators either selected the single antiplatelet therapy that could have aspirin, clopidogrel, and different combination forms of aspirin, or we could use DAP therapy, which is dual antiplatelet therapy. So we could use aspirin, clopidogrel, and it really just depended on their local stroke protocol, depending on where they were using this study at. And 63% of patients were actually put on DAP therapy in comparison to single antiplatelet therapy. And then lastly, just to make sure that the patient was getting well-rounded care, they did have secondary stroke prevention, including high-intensity statin, blood pressure management, diabetes and vascular risk factor management, and also lifestyle modifications. So for the primary endpoint, the primary efficacy outcome was time to first ischemic stroke. The primary secondary outcome was major bleeding, defined as the ISTH major bleeding scale. And for secondary outcomes, so we had key secondary outcomes that were all strokes, cardiovascular death, myocardial infarction or stroke, all-cause mortality, MI or stroke, disability stroke, disabling stroke, and then a TIA, while secondary safety outcomes included ISTH, clinically relevant non-major bleeding, major or clinical relevant non-major bleeding, symptomatic intracranial hemorrhage, hemorrhagic stroke, fatal bleeding, and major bleeding. For our inclusion criteria, so patients were required to be at least 18 years or older with a recent non-cardioembolic ischemic stroke or high-risk TIA, and they were randomized within 72 hours, like I talked about previously, and they had to be planned to get antiplatelet therapy. Some additional requirements, so at least one of the following that had to be listed there, which included non-linear infarct, history of atherosclerosis, or atherosclerotic plaque identified on imaging. For key exclusion criteria, there was a ton of different exclusion criteria, and they're all listed within like the supplementary guidelines, but these are the big ones that I felt like were important. So the patient could not have atrial fibrillation or indication for anticoagulation, active or high risk bleeding, prior intracranial hemorrhage, significant liver disease, end-stage renal disease requiring dialysis, or recent major surgery. And overall, a lot of the criteria that I did read in the supplementary criteria, it excluded patients that really I would think would be important to exclude, so I thought it was appropriate. For eligibility, randomization, and outcomes, a total of 12,578 patients were screened. They were randomized, and 12,327 patients were randomized. And based off that, we had 6,162 in the Asundexian group in comparison to 1,165 in the placebo group. So approximately half were split up. So it led to a well-balanced group between the two. For baseline characteristics, so patients overall well-balanced. The average age was approximately 68 years old. 1/3 of the patients were female, so majority of were male. Nearly 95% presented with ischemic stroke, while 5% presented with a high-risk TIA. And as you can see, majority of patients, they were all split very evenly when it came to geographic region and then also race. Majority of patients were white. Also second to that was Asian population, and then we had Black and other. For clinical characteristics, so large artery atherosclerosis was the most common stroke subtype, accounting for around 43% of the patients. The mean NIH stroke score scale was around 2, and predominantly a mild stroke population. So as we know, so majority of our patients ranging from that 0 to 46 scale. So this was a very on the lower end of our stroke scale. And approximately 63% of patients were planned to receive dual antiplatelet therapy at randomization, like I talked about previously. Statistical analysis, so target enrollment, they had a target to get to 12,300. It was an event-driven trial, so this was powered to detect a hazard ratio of 0.8 with 90% power and a two-sided alpha of 0.05. The study, like I said, required to have approximately 12,300 patients and at least 830 primary outcome endpoints. Efficacy analysis were performed using an intention to treat approach, and time to event outcomes were using Cox proportional hazardous models and stratified long ranking testing. And they also used other variety of tests that were all appropriate for what they were looking for. For our primary outcome, so the primary outcome favored Asundexian. Ischemic stroke occurred in 6.2% of the Asundexian group in comparison to 8.4% in the placebo group. This corresponded to a hazard ratio of 0.74 with a 95 confidence interval of 0.65 to 0.84 and a p-value of less than 0.001. This represented a relative risk reduction of around 26% and a absolute risk reduction of 2.2% and a number needed to treat of 46. And so this led to a significant reduction in recurrent ischemic strokes, and it looked to be consistent across most of the subgroups as well. And I wanted to include this because I felt like it gave a good visual of the primary endpoint. So this was the cumulative incidence of ischemic stroke. And so this was a Kaplan-Meier curve demonstrating the early separation between the treatment groups that continued throughout the follow-up. The cumulative incidence of ischemic stroke remained consistently lower with the Asundexian compared to placebo. And as you can see on the slide too, a significant p-value as well, and the confidence interval stayed consistent. For secondary outcomes, so several of the secondary outcomes favored Asundexian. Any stroke, cardiovascular, and myocardial infarctions or stroke and all-cause mortality, they were shown here. So if for any stroke, it favored Asundexian with a p-value of less than 0.001. For CV death, MI, and stroke, also favored Asundexian with a 0.001 p-value. And then all-cause death, MI, or stroke also favored Asundexian with a p-value of 0.003. Ischemic stroke numerically was significant, with less in the Asundexian group was not statistically significant. For safety findings, so the primary safety finding was similar between both groups. So the ISTH major bleeding score occurred in 0.9% in the Asundexian group in comparison to placebo of 1.7%. And this resulted in a hazard ratio of 1.10. Rates of clinically relevant non-major bleeding, intracranial hemorrhage, hemorrhagic stroke, and fatal bleeding were also similar between both groups. And for the safety outcomes, they just had patients, no matter what, if they received greater than or equal to 1 dose of either the placebo or Asundexian, they were included in the safety findings. Also, another visual of a Kaplan-Meier curve showing the cumulative incidence of major bleeding over time. And there was really no meaningful separation between the two groups. As you can see, at first, it looks like maybe Asundexian was going to be significant, but then it came back down. And then there was actually no significance between the two groups with a p-value of 0.46. The authors concluded that among patients with non-cardioembolic ischemic stroke or high-risk TIAs, Asundexian reduced recurrent ischemic stroke and major cardiovascular events without increasing major bleeding. And for limitations overall, so there were several limitations to consider. So this was a Bayer-sponsored trial, so they are the creators of the medication. This happens pretty frequently with a lot of our clinical trials, so just always something to consider, which this is the manufacturer of the Asundexian. The median NIHSS score was only 2, and so really a lot of these patients really only had mild strokes, if anything. High-risk TIAs only represented about 5% of the population, so this really is for our patients that have a mild stroke. And then really it was very hard to limit general ability to that population of TIAs, like I said previously. And Asundexian and placebo discontinued in about 26% of patients. So this is significant to me, as this is a fourth of the population. So really almost a fourth, well, over a fourth of the patients ended up discontinuing that treatment. And then really long-term safety remains unknown. As the study showed, there wasn't really any increased risk of safety events in those differing between groups, but we really don't know what the long-term effects of this medication would be. So recommendations. So this was a large, well-conducted phase 3 trial demonstrating a significant reduction in recurrent ischemic stroke while without increasing major bleeding. While these findings are very promising, there is some things to think about. So pros and cons of the study. So this is only a single positive phase 3 trial. So there definitely needs to be more research on this medication. This medication is also not going to be incorporated into the guidelines anytime soon. As we know, sometimes it takes a little bit of time to get the medications into the guidelines. So we won't see any of those updated guidelines just yet. And then also we won't know the cost and access to this medication. So for our patients that have any financial restraints, this could be a really determining factor if they could go home on this medication. And like I said previously, long-term safety effects are unknown, so we really don't know what that's going to look like. But overall, I would say that this is promising and appears to see maybe potentially a future option for secondary prevention following non-cardioembolic ischemic strokes and potentially high-risk TIAs. But I would first lean into more for my patients that are non-cardioembolic ischemic strokes, as that is the majority of the population in this trial. Here are my references, and I will be happy to take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only. It does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.